Good afternoon, everyone. I'd like to welcome you today to our talk on children's health and the environment with Dr. Phil Landrigan. We're extremely fortunate to have Dr. Landrigan here with us today. In fact, he was scheduled to come in October, and he agreed to come back because we had a little bit of schedule changes that we had to accommodate. And so we're just very thankful that he made the time to come back and meet with us. So I'm Deanna, Hellshire, Director of the Michael and Susan Dell Center for Healthy Living, and I'm pleased to welcome you on behalf of the center and the Austin Regional Campus. So Dr. Landrigan is really the foremost expert in the U.S. and probably the world on children's health and the environment. He's the Dean for Global Health and past chair of the Department of Preventive Medicine at the Ichan School of Medicine. As a pediatrician and epidemiologist, he's known widely for his many decades of working with children's health. He participated in the World Health Organization's global campaign to eliminate smallpox, so he really was a pioneer in that effort. He's also been senior advisor on children's health for CDC, and as well as a host of other things, including a book that's kind of a seminal book in terms of children's health and the environment. So we have a lot to learn from his experience. We're very fortunate that he's here with us today, and I'd like you to give a big Texas welcome to Dr. Phil Landrigan.
Well, good afternoon, everybody, and welcome, Deanna, and also welcome to the folks in Houston and anywhere else who are doing this remotely. It's a pleasure to be here with you today, and apologize for having not made the seminar back in the fall, but it's good to catch it here. As I was coming into the airport just a few hours ago this afternoon, I was thinking about the first time I ever came to Texas. I'm originally from New England. So Texas is a long way from where I started out. The first time I was in the state of Texas was in the fall of 1970. I was a brand new EIS officer at CDC based in Atlanta. And this was my first time in Texas and only my second time west of the Mississippi. And I went into Texarkana, Texas, Texarkana/Arkansas, where there was a big measles epidemic that was bisected by the state line, and that's it's really the first big epidemic I ever worked out, and cutting my teeth on it. And then a year or so later, my second big epidemic was also in the state of Texas, looking at children exposed to lead around the now defunct Asarco smelter in El Paso. So had a lot of good experiences in the state, been here lots of times since, but those were the first two which I well remember. So this is the topic this afternoon, and I want to begin by giving you a historical perspective. And let me start by telling you what's the single overriding message that I'd like to leave you with this afternoon. It's always, public health messaging 101. Tell people before the talk what the message is, give them the message, and tell them afterwards what they were supposed to have learned from the talk. So the single overriding message is that the environment, broadly defined, is a very powerful determinant of human health, and especially for kids, for reasons that I'll get into as we go through this. And one way to see the impact of the environment on children's health is to look at it in a historical context and see how things have changed. And over the past 100 years, patterns of death, patterns of longevity in this country have changed profoundly. I mean, this is hard to believe, but in 1900, so 116 years ago, the average lifespan in America was about 47 or 48 years, slightly longer for women than for men, as always, but the average was in the high 40s just 100 years ago. Things have changed profoundly. The infectious diseases are certainly still with us. All you got to do is hear about Zika, or chikungunya, or dengue, Ebola. but they're not the force, they're not the powerful overall force on mortality that they were 100 years ago. Life expectancy has doubled, I just said. Infant mortality has gone down and continues to go down. And the WHO initiatives over the past decade prosecuted under the Millennium Development Goals have continued to push down infant mortality in some of the world's most difficult places. And a couple of things have driven these changes. I think it's fair to say that in the early stages, the changes were driven by broad-scale environmental changes, such as bringing in clean water, cleaning up some of the worst air pollution. And then more recently, what's pushed the changes have been modern public health, vaccinations, antibiotics, and of course, modern medicine. And as many of you will know, this turnover from a pattern dominated by infectious diseases to a pattern of morbidity and mortality that's dominated by chronic diseases is referred to as the epidemiological transition. And then something else that's been going on during this time that often is below the radar but really is going to be a major part of my talk today is the fact that over the last 100 years, and most especially since World War II, so since about 1950, we have just been flooded with thousands of new synthetic chemicals that have been invented by smart chemists, put into 1 million products that we use every day, but we're now beginning to realize some of the health problems that go with these technologies. So here's the same thing again. Here's the epidemiological transition in the city where I have been for the last 30 years, New York, modestly called the, anyway. So what you're looking at here, this is the Crude death rate in New York City starting in 1800, and there's several interesting lessons. The first is that in the 19th century, the death rate was twice as high as it is today because average life expectancy hovered between 40 and 50 years in a good year. On top of that already high mortality were these horrible epidemics that came through the city in some years in New York City during that time, and I suspect every other big American city of the day as well. You had die-offs of as great as 4 and 5 and 6% of the whole city population in a single year due to some horrible disease like cholera or yellow fever that came scything through the city. It was really, really quite dreadful. The big decline in mortality began about here, 1860, 1870, somewhere in there. And of course, long before penicillin, long before the first kidney transplant, it was driven by the construction of aqueducts and reservoirs. The so-called Croton Aqueduct went in about that time. And so here's the 1918 influenza. I think a lot of times when people look at mortality statistics for the 20th century, it starts here and you say, wow, we've made progress. But it's interesting when you look at that 1918 outbreak, horrible as it was dwarfed by stuff that had occurred 50 or 60 years before it. And then here we are today. So, with life expectancy in the US now around 80-ish, a little bit more for women than for men, and probably still improving. So the chronic diseases are on the rise, and let me show you some stats on these. Here's asthma, which has more than tripled since the 1980s. It's the largest cause of school absenteeism and the largest cause of hospitalization in American kids. The next one is just more on asthma, showing, bringing it, let's see, the previous graph brought it up to 2004. This brings it up to just a couple of years ago, and you can see things are still going up, children more than adults. Here are some statistics. About 1 in 10 children currently have been diagnosed with asthma. In 2007, the most recent year for which I could get mortality data, 185 child deaths and 3,000 adult deaths from asthma, and the greatest rise among black kids. Childhood cancer. The good news on childhood cancer, of course, is that we have learned how to treat the disease. If any of you have ever been on a cancer ward, you know it's brutal, but we do get a lot of saves. 80+ in some centers now on childhood leukemia, 40-50% on brain cancer, which is the number 2. But the bad news is that the incidence has been rising, and since we started keeping national records in the early 1970s, the incidence of leukemia is up about 35-40% in the aggregate. Here's some more sophisticated data bringing it up to 2011. And then I thought I had a slide on brain cancer. I don't. But anyway, brain cancer, which somehow fell out here, has also shown a 35 or 40% cumulative increase since the 70s. And testicular cancer, everybody, especially here in Texas, here in Austin, knows about Lance Armstrong. But what I think people don't appreciate is that Lance Armstrong is not an isolated case. He's part of an epidemic of unknown cause of testicular cancer among young men. And it's interesting that along with the epidemic of testicular cancer, pretty much in temporal parallel is this increasing incidence of hypospadias and cryptorchidism. Developmental disabilities, very highly prevalent in our society. The exact number, of course, depends upon what definition you use, but I think most people that live and work in this area say it's about 1 child in 6 has some form of developmental disability, broadly defined, and the latest data from CDC using a fairly inclusive definition of what constitutes the autism spectrum disorder. CDC says that 1 child in 68 is affected with some degree of autism. Here's just some more fine detail on that. And obesity, I was talking to one of the postdocs earlier that's doing obesity research, the relationship between exercise or lack thereof and the increasing prevalence of obesity. But it's a terrible problem. It threatens to seriously erode the gains that we've made in increasing longevity. And the childhood obesity is bad enough in its own right, but when one thinks about all the diseases that follow from childhood obesity, high risk of cardiovascular disease, diabetes, it's really quite shocking. My hospital, Mount Sinai Hospital in New York City, straddles the border between 2 neighborhoods. The Upper East Side of New York, which is extremely wealthy, it's the zip code that houses the UN, among other things, the Metropolitan Museum. And then immediately to the north of us is East Harlem, where median family income is south of $10,000, 90% minority community. And we see coming into the hospital from East Harlem these enormously obese little 8 and 10-year-olds. It's just absolutely frightening to realize what the future holds for those kids if they somehow don't turn the obesity around, which is unfortunately not going to happen in very many of them. All right, so now with that as a prelude, just talking about some of the broad strokes of trends in disease in American kids, let me drill down and talk a bit more about toxic chemicals and what's the evidence that they contribute to changing patterns of disease in children. So here's the context, which I've already alluded to, the very, very substantial increase in chemical manufacture that's gone on since the 1950s in this country and around the world. And actually, one of the trends that's happening is that chemical manufacture is leaving the United States. It's diminishing in the US and in Western Europe, Japan, Australia. It's going to poor countries where there's cheap wages, that's probably the biggest driver, closer to the raw materials, no OSHA, no EPA, and therefore horrendous pollution, levels of pollution that we haven't seen in this country in decades and perhaps never actually experienced. Now, the whole chemical revolution, as I like to call it, it's a fascinating story. It's a combination of human ingenuity and human stupidity all wrapped together. The ingenuity is in the hands of the chemists, the individual chemists, the groups of chemists who invented all kinds of new products. The upper one there is cellophane. This is DDT, this truck. It's a truck, a famous picture of a truck spraying DDT on a beach in New York City, probably in the late 50s or early 60s. Here's a Union Carbide ad that says, if you can't read it, it says, "Thin synthetics, why they spell a better life for you." These new chemicals came on the market with enormous enthusiasm. I remember when I was a kid growing up in the 1950s, hearing about better living through chemistry. That was DuPont saying at the time. And new products came on the market with a round of applause. People adopted them, be the first on your block to get yellow plastic, whatever the new thing was that year. And it was a big deal. But the problem was that they mostly didn't get tested. This is a thalidomide baby. Chemical fire in the Cuyahoga River, I think that's the Cuyahoga. Toxic waste drums, steel mills. The factories were dirty, the chemicals were untested, and the environmental disasters proliferated. And of course, eventually there was a pushback. In the 1960s, Rachel Carson wrote her iconic book, Silent Spring, talking about pesticides stilling the landscape and killing the eagles and the ospreys and threatening the children. EPA was created in 71, 72. The Clean Air Act passed. A few years later, the Safe Drinking Water Act passed, and things began to get better. But we went through a very bad time back then. And even though some of the worst forms of pollution have absolutely come under control in this country since that time, the air is definitely better, the water is definitely better. The EPA statistics going back 35 or 40 years bear this out very, very clearly. Despite the great progress we've made on air and water pollution and also on soil pollution at Superfund sites, the issue of toxic chemicals continues to bedevil us. So nowadays we have more than 80,000, actually closer to 85,000 chemicals that are registered for use with EPA. The ones that really matter are approximately 3,000 chemicals termed high production volume. That means more than 1 million pounds per year. And here's the real problem. It's not that this is where the human stupidity comes in. We've been very clever at inventing the chemicals, at finding uses for them, putting them into products that we all use every single day. But we've done a rotten job of testing these chemicals for safety or for toxicity. And for half of the 3,000, forget the other 77, just focus on the 3,000 that matter, basic toxicity information is available on only about half of these. And when you talk about developmental toxicity, the ability of these chemicals to disrupt early development, fetal development in early childhood, for 80%, we just don't have any information, meaning that kids are exposed every day to chemicals of unknown hazard. Some of you may know or know of my good friend Herb Needleman, who did a lot of the great work on low-level lead toxicity back in the 70s and 80s. And one of Herb's sayings is that in our society we're conducting a vast toxicological experiment, and we're using our children as the subjects. So. And by the way, these chemicals get into us. Many of you will be aware that CDC does rolling surveys of the U.S. population through NHANES, take blood samples and urine samples from a statistical sample of the U.S. population and analyze them now for a large number of chemicals. And CDC is picking up about 200 HPV chemicals in most all of us, on almost everybody in this country. Maybe if you're the Unabomber living in the wilds of Idaho, you escape certain chemicals, but most of us who live in cities are exposed on a daily basis to an awful lot of stuff. Hopefully the levels are low, hopefully they're causing no damage, but the fact of the matter is we don't know, because they've not been tested, and we don't know very much about the toxicity of many of them individually, and we know even less about the collective toxicity of simultaneous exposure to multiple chemicals. One of the things we've learned about chemicals and human health is that children are much more sensitive to chemicals than adults. And by children, I mean embryos, fetuses, infants, postnatally, and through childhood up to adolescence. They're more vulnerable, and in particular, there are times in early development, so-called windows of vulnerability, when even a small dose of exposure to the wrong chemical can cause some devastating effects. So why are kids so sensitive? Well, first of all, pound for pound, they're more heavily exposed. They breathe more air, they drink more water, they eat more food, so they take in more of any foreign materials that are in air, food, and water. They do stuff that we don't do very often, like rolling around on the floor, putting their hands in their mouths. We might do it on occasion, but they do it as a way of life, and so a lot more opportunity to transfer material into their body. Metabolically, they're immature. Case in point, organophosphate pesticides like malathion. If malathion gets into me, I can break it down and excrete it with a half-life of 6 hours. If it gets into an infant, the half-life is 36 hours, which means that this neurotoxic chemical has much more time to cause mischief. And then I mentioned windows of vulnerability. Thalidomide is a classic example. Anybody here doesn't know the thalidomide story? I don't want to presume that you all know it. Okay, so let me take a minute. Thalidomide was a drug, a medication, that was invented in Europe in the 50s and used in the late 50s, early 60s. It was a sedative, but it turned out to be remarkably effective at suppressing morning sickness in women during the first trimester of pregnancy. So it was doctors, especially in Germany, which was the hardest hit country, in Switzerland, prescribed it to thousands of women in early pregnancy, which of course is when morning sickness is most common. And what happened was about 8 or 9 months later, they began to see an epidemic of babies like that little infant I showed you a few slides back with no arms and no legs, a condition known as phocomelia. And altogether, it's estimated that about 10,000 of those babies were born, 8,000 in Germany alone. It's a terrible disease. And a baby was born with phocomelia only if the mom took the thalidomide during, I think it was the period between like day 27 and day 35. There was a very precise period of time when the limbs are forming. And what thalidomide did was it interrupted the vascular bud into the evolving limb, and without blood supply, the limb didn't grow, and that was that. If the mother took the thalidomide a bit earlier or a bit later, and there are women who took it only like once or twice so they could pinpoint the exposure, babies were born blind or deaf, or some became autistic. And it all depended upon the timing of exposure and what developmental process was playing out on a given day. Another one was DES. You probably all know DES, right, because it's closer to the present. Synthetic hormone. Women took it to prevent miscarriage, and usually in later pregnancy. And a certain percentage of the daughters born to those women developed adenocarcinoma of the vagina when they hit puberty and beyond. And the sons weren't so obviously affected. As far as I know, no malignancies, although there's been some talk about testicular cancer, but there certainly were internal abnormalities of the Müllerian ducts and some of the other reproductive structures that are supposed to regress in males and didn't properly regress. Fetal alcohol syndrome. So these are all examples of the fetus being much more sensitive than an adult to toxic chemicals, and then there being particular little periods of time during early development when the window of vulnerability, when the exposure is especially dangerous. And then kids have more future life. So that's the theoretical background. What's the actual evidence that toxic chemicals are causing disease in children? So let's take a look at it for the various diseases that I've just been talking about. Start with asthma, where the environmental links have really been very well defined, probably the best defined of all of these conditions. And we now know that there's a whole series of indoor triggers as well as outdoor triggers that cause asthma in children. We know that, for example, when air pollution goes up, asthma rates go up. Elegant studies done by John Peters and Gauderman and Rob McConnell in Los Angeles have looked at air pollution levels in different areas of the Los Angeles basin and tracked panels of children who live in these different neighborhoods in Los Angeles. And what they find is that the prevalence of asthma is highest in the most polluted areas. So in other words, long-term exposure causes more cases, and then also the incidence of acute attacks is higher in the more polluted neighborhoods. So air pollution increases both prevalence and incidence. They're following 3 separate cohorts that are separated from each other by 8 or 10 years in age. And as the air in LA gets cleaner, they're finding that the prevalence of asthma is going down and metrics of lung function are increasing from one cohort to the next. So it's really beautifully well defined. When it comes to childhood cancer, we know a few causes, but I don't think anybody has a coherent understanding of why rates of childhood cancer have gone up 35 or 40% over the last 4 or 5 decades. We know about radiation, but if anything, we've made progress on radiation. We have many fewer X-rays going into kids today than we used to, although that's changing with CAT scans, but it had been going down. Many fewer women get X-rays during pregnancy. Alice Stewart in England showed very clearly that prenatal abdominal X-rays in a pregnant woman were associated with childhood leukemia, and that really tipped the use of X-rays during pregnancy downward, and thankfully ultrasound came along, so a technology leap. But radiation is a cause of cancer. I mentioned DES already. There's a few solvents in some towns down in South Texas, like Beaumont, Port Arthur. Benzene, 1,3-butadiene have been tied to leukemia in children. Prenatal pesticide exposure is most certainly a risk factor. The Agricultural Health Study, Aaron Blair and his colleagues are picking up relative risk between 1.5 and 2.5 for childhood leukemia in the kids of farmers and pesticide applicators. Nitrosamine. Aspartame is a carcinogen absolutely in animal studies. I told my daughters no artificial sweeteners during pregnancy, even though there's no good human epidemiology yet. The animal studies conducted in Italy are quite compelling. And then there's always a yin and a yang, and on the positive side, maternal folic acid during pregnancy reduces incidence of childhood leukemia, and longer duration of breastfeeding reduces childhood cancer. So something good is getting through. But we don't know why the upward trend. What about the reproductive disorders? We really don't know. It certainly isn't DES. That was just a small blip that's come and gone. We don't know why testicular cancer and hypospadias are going up or why sperm counts are going down. Could it be endocrine disrupting chemicals? Maybe. My colleague at Mount Sinai, Shauna Swan, finds that baby boys who are, phthalates are one of the most widely used endocrine disruptors. They're a chemical that's put into vinyl plastic to make it flexible, like this wire here that I'm holding. And phthalates are testicular toxins, especially when exposure takes place prenatally. And Shauna finds that baby boys who are exposed to phthalates in utero have some feminization of the external genitalia, and she's working on a long-term study to see if those anatomic malformations in the little boys, which are fairly subtle, they're not gross malformations, it's nothing as obvious as hypospadias, but she's doing long-term studies to see if those kids grow up to have lower sperm counts when they reach that age. So we'll see if chemicals are driving some of this. Certainly the increases are far too rapid to be genetic. Genes aren't everything. How about neurodevelopmental disorders? Well, we have a lot of evidence here. I think what typically happens is we first recognize high dose acute poisoning. This is what happened with childhood lead poisoning. The first cases of lead poisoning were diagnosed in Australia right around 1900 by a smart doctor who saw some kids coming into the local hospital with coma and convulsions without fever. So he did some detective work and found that the children were eating chips of lead paint, which at that time was a brand new product that the lead industry was aggressively marketing. Similarly, in the case of mercury poisoning, methyl mercury poisoning, the first cases recognized were in Minamata, Japan. Minamata still is a fishing village, in far southwestern Japan, where there was a chemical factory that discharged metallic mercury into the bay. Some of that metallic mercury was transformed in the bay into methyl mercury, which is very neurotoxic. Pregnant women ate fish that concentrated the methyl mercury, and they gave birth to babies with horrible neurologic impairment. And then subsequently, with more sophisticated testing, lower dose exposure, we came to realize that the symptomatic children, the Minamata kids, were just the tip of a much larger iceberg. And here's a picture of, this is an iconic picture by an American photographer, Eileen Smith, of a mother holding this little girl and bathing her in one of those traditional Japanese hot tubs. And you can see the poor child is microcephalic, blind, spastic, profoundly retarded. It was a terrible, terrible disease. And the tragedy was compounded by the fact that the mothers were physically unscathed. Psychologically, I'm sure they were destroyed, but physically, she ate the fish, she knew she ate the fish, and therefore passed the poison to the baby, but she herself was unscathed because her brain was already fully formed. So we now have a pretty good list, thanks to good prospective epidemiologic studies that have followed birth cohorts or even prenatal cohorts and measured exposures in the mother during pregnancy and then tracked the babies. Through that kind of meticulous detective work, we have got a nice list of a dozen or so chemicals that we, with a high degree of confidence, we can now link to neurodevelopmental disorders. I could add other chemicals to this list, such as ethyl alcohol, probably cocaine and other drugs of abuse, but I've restricted this list to industrial chemicals, and I've listed them here more or less in chronological order of discovery, starting with lead and methyl mercury. The developmental neurotoxicity of PCBs was discovered by the Jacobsons, a husband and wife team of epidemiologists at Wayne State in Detroit back in the 1970s. Arsenic and manganese, their developmental neurotoxicity was recognized in prospective studies in Bangladesh. The chlorpyrifos was recognized in a series of 3 studies, 2 from New York City, 1 from California, that were published in Environmental Health Perspectives a few years ago. And phthalates, bisphenol A, and the brominated flame retardants are the most recent additions to this list. The problem is that, exciting as all the science is that led to this series of discoveries, we know that there are lots more chemicals in wide use today that are neurotoxic, chemicals that have been studied in adult workers, that have been found to cause neurological injury in workers, but have just never been studied in kids. And then beyond that, there's 1,000 or so chemicals that have been found to be neurotoxic in animals, which have not been studied in humans of any age. So we have this sort of iceberg phenomenon going on. And this, I think this is the kind of thing that really makes me worry. I'm terribly worried that lurking in this pyramid, probably in this area, are other chemicals that are causing neurobehavioral damage in American children today that we simply haven't been smart enough to detect. I mean, think about the history of lead. We first recognized childhood lead poisoning back in Australia in 1904, as I mentioned to you. Despite that recognition, beginning in the 1930s, lead was added to gasoline in very large quantities to increase engine performance, to make cars go faster, to make airplanes fly better. Probably necessary in the airplanes, not in the cars. And at peak use in the United States, we were putting about 100,000 tons of lead into gasoline across the country every single year. And lead was everywhere. It was detected along highways, it was in the dirt, it was detected in cities. The average blood lead level in American children at that time was in the neighborhood of 20 micrograms per deciliter. Most of you know that today the CDC standard is 5 micrograms. If a pediatrician were to see a child today with a level of 20, they'd probably immediately send the child to the ER, but back then it was the norm. And in fact, anything under 40 micrograms was considered okay because kids weren't convulsing. And 40 was the CDC standard when I did my pediatric training. And we now know in retrospect that what we had going at that time was a silent epidemic, that pretty much all American kids were exposed to lead, were probably suffering loss of IQ, shortening of attention span. I could be a real epidemiologist instead of a medical epidemiologist if I hadn't grown up in the 70s. And you know, everybody was just a little bit duller, and we didn't even know it because it was silent, it was widespread, it was the norm. And it took us until the mid-1970s before the proper studies were done. Subclinical lead toxicity was discovered, and we took lead out of gasoline. So the question is, how many other leads are out there today? How about organophosphate pesticides? How about brominated flame retardants, which are probably in all of us, and which we now know are developmental neurotoxicants? So this is what happens when a neurotoxic chemical like lead is widespread in a society. Here's a normal place where the average IQ is 100. The standard deviation on IQ is 15. So 6% of the children in a hypothetical population of 100 million, 6 million children will be above 130, and 6 million will be below 70. And look what happens when you put a neurotoxicant out widely in the society, enough to reduce the average IQ by about 5 points, which is just about precisely what we did with lead back in the 60s and 70s. And you reduce by roughly 50% the number of really gifted kids who are going to be the future leaders of a society, and increase by 50% the number of children who are impaired, who are going to never fulfill their potential, who are going to be a burden on society, special ed, police encounters, prison, all the things that happen to kids who are a few steps slow and who have short attention spans and have trouble controlling impulsive behavior, which is all of what lead does to children. The diseases that, apart from the human cost, these diseases also have big economic costs. And at first I totally resisted the idea of putting a dollar value on human disease. It just stuck in my throat when I first ran into the concept 15 or 20 years ago. But I realized if you want to advance these issues of child health in state capitals or in Washington, talking to politicians, talking to people that have to balance budgets, who have many competing priorities, who can always put something off till the next day if it's not urgent, you've got to put dollar figures on it. You can talk about sick children, that's fine, you can put a human face on it, but you also need to put dollar figures on it and specifically impress upon the decision makers and the people that do budgets that there are real costs, maybe not visible costs, but real costs in delaying action to prevent children's exposures to toxic chemicals. And we've sharpened this message over the years. This particular table was developed by Leo Tresande, who is at NYU, who trained with us a few years ago. And his best estimate is this one. He calculates that these 6 or 7 diseases, not looking at the entirety of those diseases, but just looking at the environmentally attributable fraction of those diseases, that they cost this country $76 billion per year, and that was in, I think, 2011. So it was 2009 data that he uses for that. So if you wanted to calculate what it costs, what these diseases cost the state of Texas, it's actually pretty easy. All you need to do is figure out, which somebody already knows, what percentage of America's children reside in Texas, which is probably, what, 8%, 6%, some such number. And the disease burden on the state of Texas is 8% or whatever it is of 76 billion, which ought to be enough to persuade your lawmakers to step up to the plate and do some stuff. If anybody wants to talk about that, we've had a lot of experience the last decade beating up on our legislature in Albany and actually gotten some good programs out of them. So what do we need to do to turn this situation around? I think it's got to be a multifaceted strategy, not no one element is sufficient. These are some of the key ones, and I'll dig in on a couple of them. So let's start with testing chemicals for toxicity. I think if you were to ask most Americans is the question, do you think that the government is somehow looking out for you and protecting you against chemicals in everyday products? They would say, of course. We have the EPA, we have the Consumer Product Safety Commission, we have state agencies. People are protecting us. Well, sorry, they're not. Nobody is. The government is doing a good job protecting you against bad medications, or at least against bad prescription medications. The Food and Drug Administration does a meticulous job of requiring that new pharmaceuticals be tested for safety and efficacy. Over-the-counter drugs, forget about it. The Senate passed legislation about 20 years ago that basically exempted them from any regulation. So when you go to one of those nutrition centers and buy stuff over the counter, you're rolling the dice. But at least with prescription drugs, the government's looking out for you. With pesticides, they are to some extent, not perfectly, but there is a pretty good law on the books when it comes to pesticides, and pesticides have to be tested and reports posted. But when you get beyond pharmaceuticals and pesticides into what's called industrial chemicals or consumer chemicals, same thing, the 80,000 chemicals that I'm talking about here, the only piece of legislation on the books is a law that was passed back in 1976 called the Toxic Substances Control Act, which was well-intentioned when it was passed. It was intended to test new chemicals before they came to market, and then to catch up with the approximately 60,000 chemicals that were on the market at that time. But in reality, it's been a bust. The law was defanged by the Congress within a year of its passage. 20,000 chemicals, the 60,000 chemicals that were then on the market were just retroactively baptized and declared safe, and no further testing was required of them. There's been another 25,000 chemicals brought to the market in the 40 years since the Act passed. 5 chemicals have been pulled off the market during that time. So it's toothless, broken, obsolete legislation that simply fails to do its job. Meanwhile, in Europe, the Europeans have, in 2007, passed legislation that goes by the acronym of REACH, which is doing a very good job of pinpointing widely used consumer chemicals, and it's starting to take chemicals off the market. One of the consequences of REACH is that multinationals who can no longer sell tainted products in Europe are repackaging those products and selling them here in the USA. There's an investigative journalist named Mark Shapiro who has written that up. It was actually Ann Robertson that called his book to my attention many years ago. Our Congress has been struggling to pass chemical safety legislation, but it ain't going to happen, not in this Congress. Okay, how about in research? We've done a nice job in this country in researching children's environmental health. The feds, since the late 1990s, the feds have put millions of dollars into this through the National Institutes of Health and to some extent through CDC and EPA. We now have a national network of roughly a dozen children's environmental health centers across the country. Different centers are focusing on different diseases, and they have done some excellent research. And we've also put money into prospective epidemiologic studies that sign up women during pregnancy, measure their exposures through one means or another in real time as those exposures are actually occurring during pregnancy, and then follow the babies longitudinally. And some of you are epidemiologists, and this will be old hat to you, but for those of you who aren't deep dipped in epidemiology, a word about prospective studies. So sort of the grandmother of all prospective epidemiologic studies is the Framingham Heart Study, which launched in 1948 in Framingham, Massachusetts, which is outside Boston. And the reason that they chose Framingham for this study was that the Public Health Service had previously done TB studies there, and they knew the local health officer. It was mundane as that. And they signed up the whole town, all the citizens of the town of Framingham, did physical exams on them, got blood pressure, took some blood samples, took a history of smoking and so on. And within a few years, they had identified all the major risk factors for heart disease that we now know. And it was very necessary because that 1948, right after the war, something like 80% of American men smoked. Not so many women back then, but 80% of American men. Anybody know what's going on here? Huh?
Smoke them if you got them.
I can't hear you.
Smoke them if you got them.
That's it, yeah. Philip Morris generously giving out cigarettes to the GIs during World War II, and the slogan was, smoke them if you've got them, right? Yeah. And so the kids that went off to war, the ones that made it back, came back smoking. That's what happened. So I know there's some tobacco epidemiologists in the room here, so you cannot participate in the quiz I'm about to impose upon you. But for those of you who are not part of that fraternity, let me ask you a question with 3 possible answers. Do you think that rates of heart disease have gone up since 1948, stayed about the same, or gone down? So how many think rates have gone up? Okay, good, about 20%. How many think they've stayed roughly the same? Okay, a few more. And how many think they've gone down? What? No, I'm talking rates, not actual numbers, rates. So it's adjusted for the denominator. And how many think rates have gone down? All right. So the 3C was correct. Here's the actual data. It's been this enormous decline. One of the best kept secrets in American medicine is the fact that there's been a more than 50% decline in cardiovascular mortality since the Framingham heart study. And people that have parsed this out and tried to break it down say that roughly half of that is due to primary prevention, going after risk factors, reducing smoking, controlling hypertension, cholesterol, etc. And the other half is due to advances in modern cardiology that enable people to live to fight another day after they've had an acute MI. And the combination of the two has just really been amazing. And when I talk to people that do oncology for a living, this embarrasses them because, you know, the oncology community has put about 98% of their money into devising ever more clever ways to treat cancer and eke out another month of life in somebody who's already got the disease, but they haven't put the energy into identification and prevention of risk factors that the cardiologists have. And it's made an extraordinary difference. But also, apart from the cardiology situation, it's a model. The Framingham study and its consequences is a model for what we think that big prospective studies of children's health could do to improve child health in this country. So a number of countries around the world and some states in this country have launched prospective studies using various designs. We actually tried to get one off the ground here in the United States, the National Children's Study. I've put it in gray because it's been in limbo of late. But it was launched, it was authorized by the Congress in the year 2000. The plan was to enroll 100,000 children in sites across the country and follow them from pregnancy to age 18 or 21. Unfortunately, it collapsed under its own weight. People in Washington tried to load too much into the study. It got too cumbersome. They also made what I think was a terrible decision to do recruiting door to door rather than through hospitals or birthing centers or prenatal clinics. So we were assigned responsibility for leading the National Children's Study in one of the boroughs of New York City, Queens, the borough where the airports are located, the single most diverse community in America. More than 150 languages are spoken in Queens. Many immigrants, some of them documented. So you walk up to somebody's door, and we had people, we even had people recruited from the local communities representing them, the many different nationalities and languages, and they would knock on the door and they'd say, "Hi, we're from the National Children's Study. Is anybody pregnant?" It was impossible. It's no way to recruit pregnant women into a study where you want to establish a relationship where you can follow the family for 21 years. It just doesn't work. There's no pre-existing bond of trust. Who are you coming to my door? So we found we had to knock on 500 doors to recruit one baby, and we succeeded in recruiting 200. So you can imagine how hard our teams worked, and even so, it was a disaster. It totally was a budget buster, and some of the other places around the country, like Salt Lake, did a bit better because they have a more homogeneous population. but by and large it was not good, and finally the study had to be folded up. Fortunately, they've rebooted it, and just yesterday the National Institutes of Health announced that a brilliant guy named Matt Gilman is going to head up the rebooted thing. It's not going to be a single top-down study the way the National Children's Study was. It's going to be called ECHO, Environmental Influences on Child Health. And what they're going to do is, it's going to be, I call it a confederation of many smaller studies that are going to be pulled together with common methodologies to the extent possible. It's not perfect, but at least we'll have something. In the meantime, the Japanese, where's the Japan Environment and Children's Study, which was roughly modeled on the US National Children's Study, they avoided our mistakes. They recruited through 15 regionally distributed hospitals across Japan in all 4 of the home islands, and they've successfully recruited 105,000 mothers and infants and are now following them. Sort of like GM versus Toyota. We had the idea, but they did the engineering. And they're going to get some excellent data out of that. So, there's also a few things going on in pediatric practice to improve delivery of care to children to protect them against environmental hazards. CDC has set up this national network of pediatric environmental health specialty units. You have one here in Texas. I think I have a map coming up. Yes, and the Region 6 is in Tyler. That one there, Tyler, Texas. Looks like Dallas to me. Tyler's further east, right? But anyway, I didn't make the map. And I want to close in the last couple of slides by talking about prevention. And science-driven prevention, where we identify risk factors and go after them in a knowledge-based fashion, can be enormously effective in children's environmental health. And my favorite example, because I was involved in one aspect of it, was the removal of lead from gasoline. So I talked about how back in the 1970s we were putting something like 100,000 tons of lead into gasoline every year. In the mid-1970s, EPA made the decision to take lead out of gasoline, and that decision was driven by the convergence of 2 findings. First of all, the realization that lead was causing subclinical neurotoxicity in children, and at the same time, the automotive manufacturers began to recognize that lead in gasoline was destroying the catalytic converters that were required beginning in the early 1970s on new cars under the Clean Air Act. And those catalytic converters had platinum in them, and you couldn't just throw platinum away, right? It's expensive. So the kids and the converters came together, and EPA began phasing lead out of gasoline by basically saying, okay, all new cars that get manufactured starting in 1975 or 76 have to run lead-free. So that means it took about 10 years to get the clunkers off the road. So we had this phase down going on. And it was predicted when they started taking the lead out here that there'd be a little decline in blood lead, but in fact, this is what happened. The average blood lead level, this is all ages, was 16. Children would have been about 20. Came down in very, very close parallel with the decline in use of lead. So it came down by about 50% in 4 years, and it's continued to come down since that time. So we've achieved something like a 90% reduction in blood lead levels in this country between 1975 and 2000. So here are the consequences. Besides the reduction in lead levels, we had a huge reduction in lead poisoning, and we had a gain in population mean IQ. Joel Schwartz, who's an epidemiologist at Harvard, has studied this, and he's tried to monetize it, and he calculates that gain in IQ has returned $200 billion to the economy in each birth cohort, each annual crop of babies born since about 1980. And the way that works, the math is very simple. 4 million babies a year, give them each 5 IQ points. So that's 20 million new IQ points per year. The economists say that an IQ point is worth about $10,000 over a lifetime because bright people are more economically productive, at least as a statistical rule they are. And so that, you multiply 4 million times 5 times 10,000, you get 200 billion per year. Every single crop of babies born since 1980. It's a huge boost for the American economy. And other countries copied us. This was a place where the United States was a true global leader, and about the only countries in the world that still use lead in gasoline are some beauty spots like Afghanistan, Yemen, Libya, and of course North Korea. This is an interesting thing here. This is the murder rate against blood lead levels lagged by 20 years. Is it cause and effect? I don't know. The graph comes from Rolling Stone, but but it's something to think about. So where does that leave us with lead poisoning, especially in this season of Flint? So we're in this very paradoxical situation where we've gotten rid of more than 90% of the lead in this country and clearly reduced the incidence and the prevalence of lead poisoning and helped a lot of children. But we're left with this, what some people have called the social crime of residual lead poisoning, the 5% or so of kids who still have lead poisoning, who are clustered in inner city neighborhoods, who are poor, who are a minority, Black and Latino mainly, who are bearing a disproportionate burden. And I think it's time that we get rid of lead poisoning in this country. We got rid of smallpox around the world. As Deanna mentioned, I had a tiny piece to play in that. And we know how to do it. We need to build a national map, which is already well under construction, of every source of lead in this country, house by house, neighborhood by neighborhood. We need to create a green jobs program to train young men and women to safely remove the lead, and we need to put the money into the program to do it. I had an essay in Time magazine a few weeks ago saying this is what we're going to do. So we'll see. But now's the time. Maybe we can get a bounce from the Flint tragedy and do something about it. So that's it, and thank you very much.
So we have time for a few questions.
Okay.
If you don't mind. Does anybody have any questions?
I'm going to ask the first question.
Sure.
Going back to the Flint study you mentioned, what are you expecting to be the long-term consequence of exposure besides the lower IQ?
So the question is, what are the long-term consequences of lead exposure in a place like Flint? So lower IQ, first of all, which you mentioned, but also other neurobehavioral symptoms, shortening of attention span, interference with what the psychologists call executive function, which is prefrontal stuff, the ability to control impulsive behavior. And that, it sort of makes sense if you think about crime, if you think about lead and crime, kids who are a little dull, who have a short attention span, and who have trouble controlling impulsive behavior, that's like a prescription for getting in trouble with the law. And whether that murder graph is true fact or just an interesting association, I don't know, but the biology is there to support the concept.
But per my understanding, the other home is Detroit, Michigan. Per understanding is exposure to lead in Flint was only about a year or so.
About 2 years.
2 years. So
Yeah.
the cumulative consequence of lead is not as harsh, or should not be as harsh as what you demonstrated for by gasoline exposure.
Yeah. So the big source of lead in this country, it's not water. I mean, lead from water certainly takes place, but the big source is paint, old lead paint, and the dust that erodes and scrapes off the lead paint. And probably, I don't know the exact percentage, I'm not sure anybody does, but probably 95% of the childhood lead poisoning in this country is related to lead paint. And that's where the real effort needs to go. And we know how to do it. I mean, we don't need to do any more science on this. We need to basically do the job. So, yeah.
Wasn't there like a class action lawsuit in Rhode Island?
Yeah. And yes, Ann Robertson asked about a class action lawsuit in Rhode Island. This was a fascinating case. I was involved, full disclosure, I was involved as a witness for the state of Rhode Island. And the Attorney General who brought the suit was a man named Sheldon Whitehouse, who's now a United States Senator from Rhode Island, a really very smart and caring guy. So basically the essence of the lawsuit was that the state of Rhode Island, which by the way, it's the smallest state with the longest name. The full name of the state is the state of Rhode Island and Providence Plantations. Probably most of you didn't know that. The state of Rhode Island brought suit against the big lead manufacturers, Sherwin-Williams, I remember, and there were others. And the grounds of the suit, the legal theory, was that these companies had knowingly sold a hazardous product in the state. Lead paint had been recognized to be toxic to kids first in Australia in 1904. The first American cases were reported out of Boston around 1912 or so. And yet they sold this stuff in Rhode Island until it became illegal to sell lead house paint, which was in about 1977. So for 50 or 60 years, the state of Rhode Island argued that these companies had knowingly sold a toxic product and aimed it right at kids. They showed the advertisements that the lead industry had produced during those years, talking about how lead made children's lives beautiful and better. So very great. If you go on the internet and look up some of the old Dutch Boy ads, Dutch Boy was one of the paint companies. They're graphic. And the first case, it was before a jury, a 6-person jury. The first time around it ended in a hung jury. The jury couldn't decide. The state brought the case the second time and they won. The state won a decision against the lead industry. And it went to the Supreme Court of the state of Rhode Island, which threw it out without explanation. Go figure. So and the intention was to collect money from the companies which would pay for the removal of the lead paint from the homes in the state. So, yes, ma'am.
If you could send a team of nurses into every prenatal class in the United States and they could say 3 things about environmental threats to their babies in utero, what would be the top 3 things that are simple for pregnant women to do to try to keep their babies healthy?
Okay, and this is apart from general nutrition and
Right.
taking care of yourself and not smoking and not drinking and not doing drugs of abuse. Okay, so over and above that, the first thing, it's probably less of a problem in Texas than it is up in my part of the country, but for God's sakes, tell pregnant women and their partners not to scrape old lead paint during pregnancy to try to make the nursery perfect for the new baby. We get a couple of cases of this every year still in the year 2016 of usually a young couple just living in an old house, deciding they want to make this room a perfect nursery for the baby that's due next August. And they scrape the paint, they create dust, the pregnant woman inhales it, and she suddenly shows up in the emergency room with a blood level of 50. You know that lead has gone through to the baby, and you've got a mess on your hands. So that's so easily avoided. It's something not to do. Just don't do it. The second thing I would say is avoid completely, or at least minimize, the use of pesticides during pregnancy. If you have to treat your house for pesticides, get out completely for a few days until the stuff settles. But if you can possibly live without treating your house or your lawn or your garden during the pregnancy, that's a good thing to do. Those would be the first 2. And the third one is watch what you eat. I mean, I understand that pregnant women watch what they eat anyway, and they're told to eat a lot of fruits and vegetables and consume lots of folic acid and vitamins. But I'm thinking in particular, avoid those types of fish that have high concentrations of mercury and PCBs. And basically, these are your big fish species, your swordfish, your tuna fish, your whales, if people down here eat whale, because those are the fish that are at the top of the food chain and build up high concentrations. Pregnant women should eat fish because the omega-3 fatty acids in fish are very important for the baby's brain development, but you got to eat the fish that are at the bottom of the food chain, trout, flounder, stuff like that, salmon. If you needed a fourth, it would be avoid toxic plastics, not this one, but avoid phthalates and bisphenol A. Yes?
Talk about prenatal exposure to tobacco, smoke, cigarettes, and nicotine as a ubiquitous exposure 50 years ago, and its relationship. Some would say, and in the Surgeon General report, that there is a relationship between these impulse control disorders and other things, but the effect sizes are modest. Let's say. Could we characterize the IQ impact of tobacco exposure
I think it's, I mean, you know this better than I do because it's your world, but tobacco, the use of tobacco products during pregnancy is associated with a whole range of adverse birth outcomes. I think the one that's probably best known is the fact that babies born to women who smoke during pregnancy on average weigh about 200 grams. 200 grams, right? Is that the right number? Less at birth than non-smoking moms. But there's also been a lot of work done on the toxicology of nicotine, in particular. Ted Slotkin, who's a superb toxicologist at Duke, has studied nicotine in rat models. And Susan Murphy, who's his colleague now in the Department of OBGYN at Duke, is doing parallel studies in children born to moms who smoke. And what they find in both the rats and in the babies is that there seems to be an increase in the rats. They tested in various mazes and stuff. They find a shortening of attention span, and that translates, they think they're studying an increased risk of ADHD in the babies. And I think anybody who tells you that a certain amount of brain damage in a child caused by some preventable exposures, and they tell you, oh, that's just a small amount of brain damage. We used to hear that stuff from the lead industry back in the 70s. And it was interesting, it was always about somebody else's kid when they said it. It wasn't their own child whom they wanted to get into UT or Harvard or Stanford. But when people use that kind of language, the shutters go up, and I just almost automatically disbelieve them, because the human brain is such a wondrous creation, and it's so incredibly highly evolved over the millennia and enables us to do so many things that it makes my little Dell laptop look like a child's toy. And anything that shaves off a few percentage points of function in the few areas of the brain that we can measure, let alone all the areas that we don't know how to measure very accurately, it's got to be taken, in my mind, very seriously. So I think it would be cool to do those kind of studies with e-cigarettes, because like as you and I were talking over here before we got started, we don't even know what's in e-cigarettes. I mean, you know nicotine is there, so that's a starting point, but what other stuff is in there? Who knows? So be your next RO1. Yeah. Yeah, in the back.
Speak to the magnitude of impact about nutrition around lead levels, so preventatively you can consume certain nutrients that will help. Is that just sort of a stand-in or stopgap measure, or is it a
No,
part of?
so for the people on the remote here, she asked about good nutrition. Does it offset lead poisoning? It helps. I mean, obviously the best way to prevent lead poisoning is to prevent exposure to lead. But if a child is exposed to lead, take Flint for an example, what are you going to do about these children who've been exposed? And there's no question that good nutrition is important. The other thing that a lot of us in the pediatric community have talked about with those children and with children in general who are exposed to lead is educational enrichment programs. I mean, if you think about it biologically, the educational enrichment programs are not going to replace brain cells that have been killed by lead, but what they will do is they'll give the children skills, the ability to work around, the ability to cope. And lots of people come up with workarounds for all kinds of health problems, and I think it's an effort to put money into giving those kids the best shot at life is money well spent.
We have two quick questions.
Okay.
Hello, Dr. Landrigan. At our last scientific symposium, Dr. Philippe Grandjean presented on brain drain, and I know that you have collaborated with him extensively on that. And Lauren Patricia, if you could just share with us maybe a few examples of what you would think in terms of risks related to maybe wireless technology and what we hear now about the use of cell phones and laptops and stuff.
Sure. So you asked about my friend and colleague Philippe Grandjean and his work on what he calls chemical brain drain. And really what he's talking about is this, that there are a bunch of chemicals out there that we know are toxic to the developing brain, and many more that we worry might be toxic to the developing brain. And his mantra is that a child has only one chance. A child in the womb and in the first years after birth has only one chance to grow a brain. And the reason for that, think for a minute about the embryology of the development of the human brain. The brain begins as a strip of cells along the back of the embryo, just a few weeks into pregnancy. And around week 5 or week 6, it forms up into a tube that runs north-south on the baby's back. And the head end of the tube is going to be the brain, the lower part is going to be the spinal cord. And then over the next 7 or 8 months, between then and delivery, that relatively small number of cells that forms the tube has to divide, multiply, and migrate such that by the time the baby is born, there are more than 1 billion cells with more than 1 trillion precisely engineered connections, synapses between the cells. And all of that stuff is incredibly complex to begin with. It has to proceed in the proper time frame. If the sequence of events is disrupted, neurons don't move to where they're supposed to go and connections get lost. And so it's just incredibly important to protect babies against neurotoxic chemicals. And that's the essence of Grandjean's teaching.
One more question?
So I appreciate your question about asking what are the top 3 things that nurses can communicate to pregnant moms. How do we get that information into the hands of all nurses, all doctors? I was recently pregnant and received very little to no information on environmental toxins, and that is very alarming to me. So how do we, is that medical training? How do we get that information spread?
Yeah, that's a good question to end on, especially in an educational environment like this. The question was, how do we educate doctors and nurses and other health professionals about environmental threats to children's health? So I think start with the beginning. The fundamental problem here is that the average American physician gets 6 hours of exposure to topics in environmental health as she or he goes through medical school. I don't know how it is in nursing school, I just don't know, but people have actually done surveys in medical school, so that's where this number comes from. We've done surveys of practicing pediatricians up in New York State, and virtually all of them, more than 90%, report that they see children in their clinical practice with diseases that they feel were probably caused or aggravated by environmental exposure. So the pediatricians are seeing these problems. Then you ask them the next question, what do you feel comfortable, we had a series of questions, what do you feel comfortable about treating? Well, they feel pretty good about lead poisoning. They know about lead poisoning. They feel pretty good about asthma because they see a lot of it. But beyond those two, they feel very uncomfortable. They don't know much about pesticides. They don't know much about other metals other than lead. They know next to nothing about plastics, chemicals, or brominated flame retardants. So we've developed a couple of strategies for trying to fill this void. One part of the strategy is this national network of centers of excellence in children's environmental health that I showed that map here. We have these 10 centers around the country which serve as referral centers for practicing pediatricians. So if a pediatrician, a nurse practitioner, a family doctor sees a kid with what they think is an environmental problem, they can get on the phone or physically send the family to one of these centers and get an opinion, same as you would in pediatric neurology or hematology. And we're trying to persuade CDC to put more money into these. Up in New York State, we tortured the state legislature until they finally gave us some money to grow our little center in New York City out, to multiply it. And starting this year, we're going to have 6 children's environmental health centers across the state of New York, and also a satellite down in Puerto Rico. And hopefully other states will follow that model, because these things are cheap. They're $100,000 a year per center. It's just not, it's not big bucks. It's part of a pediatrician, part of a nurse, part of a social worker, part of an environmental person. And that's about all you need in a good telephone. And we're doing just educate, grand rounds whenever people give us the opportunity. Yeah. Okay, so.
Real quick.
Just because there's a new group called Run Safety Nurse, and it's just putting out, and that's what their mission is to educate
Thank you, Ann.
So thank you again, Dr.
You're very welcome. You're very welcome. Thank you.